Good morning, everybody. We are going to start with this symposium. First of all, I would like to welcome all of you. Thank you very much for joining us to this Biotech Healthcare Symposium at the 43rd Congress of the ESCRS. First of all, I would like to thank Biotech Healthcare for their trust they have placed in me for moderating this session. And I would also like to thank our fellow panelists and speakers. I am very well accompanied. We have three speakers. Dr. Cabanas from Spain, head of the department of the University Hospital Virgen del Rocío in Sevilla, and two speakers from India, Dr. Ramamurthy and Dr. Ganesh. They are both leading names in the cataract and refractive surgery. And also we have two fellow panelists, Dr. Cancino, on my left. He is a leading cataract and refractive surgeon in Spain, and Dr. Geckel from Germany, another leading cataract and refractive surgeon. So we are going to start with the scientific program. We have three hot and nice topics with three great speakers. So I encourage all of you to engage with the speakers and the panelists at the end of each talk for doing 5-7 minutes of questions and answers. So first,
Good afternoon, everybody. And at the outset, I would like to thank Biotech for inviting me to share my results with the Eyecryl Phakic lens. I am a consultant for Biotech. So what is new about the Eyecryl Phakic lens? It has an innovative lens design with advanced material for better biocompatibility and stability. So it gives you an effective refractive correction and also increases safety, minimize the risk of complications so that you have a safe and reliable option to correct myopia and myopic astigmatism. So let's look at some of the features of the Eyecryl Phakic IOL. One is the sustained visual acuity. So patients have demonstrated consistent visual acuity improvements, achieving better than 20/25 in the long term. Several studies have demonstrated this. Also, positive patient satisfaction, improved quality of life, and reduced reliance on glasses. A very high refractive stability over a period of time. There's hardly any regression. So it is a permanent correction and minimal changes over a period of time. Now let's look at our data and the study that we did. This is the pre-op demographics. The corrected distance visual acuity pre-op was 0.05 logmar. The average sphere was minus 9.91, so fairly high myopia. Cylinder was minus 1.67, spherical equivalent minus 10.74. And we also look at the sulcus to sulcus with the UBM, and the average was 11.72. Average anterior chamber depth was 13.19, and the average white to white was 11.83. The mean follow-up, again, this is a long-term study. The mean follow-up was 38 months, so more than 3 years. And the range was from 2 years to 5 years. This is the visual and refractive results at 2 weeks and 3 months, 38 months post-op. So the uncorrected visual acuity you can see from 2 weeks to 3 years is 0.01 logmar, hardly any change. Corrected distance visual acuity also 0.01, even at 3 years average. The sphere, this is very interesting, minus 0.03 logmar. Again, after 3 years, same minus 0.03. So hardly any change in the refraction. Cylinder, there was a slight change from minus 0.06 to minus 0.08, probably because of the wound healing and epithelial changes. And the central vault you can see change from 2-week post-op 497 to 481. So it reduced by about 15 microns. We all know that the vault actually reduces every year about 8, on an average about 8 to 12 microns. So this is because of the increase in the and growth of the crystalline lens. Okay, so if you look at the cumulative uncorrected visual acuity at 38 months post-op, we find that 83% of eyes were 20/20 or better, and we had about 12% 20/16. That's quite good. If you look at the safety, which is gain or loss of lines, you can see that only 1% of the cohort had loss of one line, and no change in 49%, and about 50% of eyes had gain of 1 to 3 lines. And this we see in most phakic IOLs because of the magnification factor. You have the high plus lens, which is a cornea, and you put a minus lens, which is the phakic IOL, and you have like a Galilean optics, which cause some amount of magnification. So most of the patients, almost 50% of patients, actually see an improvement in best corrected visual acuity, and the safety index was 1. This is the attempted versus achieved spherical equivalent at 38 months, and you can see that the scatter is quite tight along the central line, a slight undercorrection for higher amounts of myopia. Again, some outliers beyond 23 diopters, because the lens is available maximally, maximum correction is minus 23 diopters. We had some patients who were actually slightly more. So you can see that the R square here is 0.9937, so very good correlation between the predicted and corrected power. If you look at the prediction of spherical equivalent, 87% were within half a diopter and 98% within 1 diopter, which is excellent considering some of these patients were very high myopes, more than 20 diopters. This is the predictability of astigmatism at 38 months, and here you can see that the astigmatism correction is quite good at 96% within half a diopter cylinder and 100% within 1 diopter of cyl. This is again very interesting, which is stability of the spherical equivalent correction at 38 months post-op, and you can see that the stability graph, the average power corrected spherical equivalent was minus 10.74. And you can see between this is 6 months and 38 months, you can see hardly any change. Percentage of eyes that change more than half diopter was 0%. So this is something which is very nice. Again, very high myopes. Also, the stability is very well established. So this is a rotational stability of the Eyecryl Phakic toric and the regular lenses at 38 months post-op. You can see that 186 eyes were included in the study. 152 received toric implants and 34 were non-toric, but we looked at the rotation of even the non-toric implants. The average post-op rotation was 2.96 degrees, so this is actually excellent. So you hardly have any refractive shift because of the rotation, and all of them were within 10 degrees. So to conclude, the Eyecryl Phakic IOL and the Eyecryl Phakic toric IOLs demonstrate excellent and high patient satisfaction, visual and refractive outcomes, long-term stability and safety profiles. Also, let's talk about the new Biotech calculator. So let's look at what is new here. Some of the features that have been implemented are there's an enhanced parameter precision. There's an improved size selection algorithm which looks at rotation also while considering sizing. And also there's an innovative region-specific lens calculator that enhances the precision. And it also introduced the latest measuring instruments where you can select from an array of instruments for size selection. Plus, like the previous speaker mentioned, it's got advanced machine learning approach for the vault prediction. So parameters which are crucial for the calculation, you have the white to white, and you can put in the sulcus to sulcus, spur to spur, or angle to angle. the anterior chamber depth, and the final axis placement of the IOL also is taken into consideration with this new calculator. Based on these parameters, the Biotech has developed its own nomogram. So let's look at the position and how it varies. Ideally, in the horizontal diameter of the sulcus is smaller than the vertical. We all know that the sulcus is vertically oriented, with the largest diameter being in the vertical axis compared to the horizontal, which is the opposite of the limbus. The mean difference between the vertical and horizontal diameters are 0.67 plus or minus 0.26, so almost 1 millimeter difference between the vertical and horizontal. And if you look at the mean diameter standard deviation of the ciliary sulcus, in the horizontal meridian it's 11.32, in the vertical it's 11.99, and in the oblique it's like 11.55 at 45 degrees and 35 degrees. So there is a difference in the sulcus, and this will again determine the lens selection. This is an example. If the pre-op cylinder is about -3 and it's placed at 4 degrees, which is almost in the horizontal direction, then you can see that the rotation is very minimal, and the calculated lens for the final lens selection is PC125T, which is 12.5 mm in diameter. Now for the same lens, if you actually rotate it more, say instead of 4 degrees it's -3 at 15 degrees, then the amount of rotation is more. So when you rotate it more in a vertically oval sulcus, then the stability reduces, because these two haptics, though the rotation is 15 degrees, if you look at this axis between the opposite haptics, it's almost 45 degrees, and here the contact reduces. So what Biotech does is, depending upon the rotation, they actually go one size up. So instead of a PC 12.125, it's a PC 130 now, with increase in the diameter by 0.5 mm. So here, because of the rotation, the lens selection is 13 millimeter. So next is to improve the size selection. Now you can input data from a maximum of 5 different biometric measurements, 5 different instruments. For example, you can have the digital calipers and pentacam, then you can put in these two. If you have 5 instruments, then you can use 5 instruments. So, and it takes the average mean and then decides the size. So this is the input value, and then final recommended model. Even if there is some amount of difference, it averages it out. So it's also got a region specific calculator. So if you look at the region here, you have rest of the world and European. There are 2 specific selections that you can use, and then the instruments for European region, you can see that there's a big list, almost 19 instruments in which you can put the input. And if you look at the vault prediction correlation, like the previous speaker has already spoken in detail about this, the R square here is 0.51 for plus or minus 100 microns, and the prediction is quite good. And this is the predicted scatter plot. So you can see most of it is in that range between 200 to 800 microns, which is acceptable. And these are the percentages for various range of vaults. So if you look at plus or minus 300 microns, 96.30% of eyes were within plus or minus 300, 83.9% plus or minus 200. So you also have, you can put in the instrument selection for lens rise, and you can either use the MS39, the Cassia, Antirion, etc. So you can use one of the 5 specified instruments, and then correspondingly you can put in the lens rise. And this actually improves the predictability. And then this is the final PDF that you get, which has the date of birth also now and the recommended model in highlighted text. So here it is PC 120. It also shows you the selected region on the PDF and all the instruments used for the white to white, and the IOL model size is calculated based on the different instrument data, and it also gives you the predicted post-op vault, so you can actually plan your size. So to conclude, Biotech's new calculator with vault prediction feature and provision to enter data from multiple equipment is very useful, because different practices have different instruments. Some practices have many instruments, so the more inputs, the better the predictability, and it increases the safety for patients and also convenience for the practitioners. Thank you very much, and I would like to invite you to our course in Bangalore, which we're having the London Vision Clinic course in 2 weeks. And if you're interested in learning more about refractive surgery, then you can come to this course. Thank you very much.
Thank you very much, Dr. Ganesh. We have 5-7 minutes for discussion. Any questions from the audience? Any question from the panel? Okay, so I would like to ask both of you. Probably there is people in the audience that wants to start implanting this Eyecryl Phakic IOL. What advice would you give them in terms of the surgical technique, and also as we have seen with the calculator, it can be used with several devices. Which device do you think is the more useful, or the one you can achieve better outcomes?
Well, if you want to start using phakic IOLs, I think the Eyecryl Phakic is the most friendly lens to start with, because the loading is very easy. It's like you load your regular intraocular lenses for cataract surgery. It's a butterfly cartridge, so it's very easy to load. With the new injector, the Medicel injector, you have to be careful. It's a little different, because you have to load it with the concave side above and with the hole on the right side, which is a little different from the other injector. And you have to see that the bevel is facing down when you actually introduce it into the eye. Also with the Eyecryl Phakic, you have a very controlled opening of the lens, and it never flips as compared to the other phakic IOL. So it's so much easier to use. It goes in through a 2.8 mm incision, so you don't have to enlarge it. And then the induced astigmatism also is lower. The placement is quite easy because it opens up very gently, and the haptics are a little stiffer. So it's easier to actually put it under the iris, and it sits better in the sulcus. So these are the few advantages of the Eyecryl Phakic for beginners. It's so much easier, less complex to use. And as far as the calculator goes, yes, you can use any instrument you have, either the digital white to white or the Pentacam, the MS-39. In our practice, we use the digital caliper and the MS-39. We also look at the lens rise. If you put in the lens rise, then the accuracy improves. So if you have a device in which you can calculate the angle to angle and the lens rise, then that's even better.
I completely agree with Dr. Ganesh. For beginners, surgery is very easy. It's the reality. It's very safety, and you just have to be careful with once you are going to put inside beyond the insulcus. But I can't say that I don't have anything important or different than in ideal surgery that could be different or something more difficult than any other phakic IOL. It's very easy. And for the devices, the main advantage is that you can use whatever you have, the device that you have. If you could choose, I will choose an last generation OCT. of course, because UVM is more difficult for patients. Has more variability, and I think the choice is the best OCT that you can manage. But if you don't have the last generation, you could use the ones that you often use, and as much measures you have, more sure you are going to be about prediction. For me, this is the last message.
We actually use a UBM also because sometimes you have outliers and you also have irises. So irises are something that you can't see with an OCT. And if you have an iris cyst and you're planning a toric, then it becomes difficult. You may have to kind of exclude, or if you have an iris cyst, it's non-toric, then you can adjust the placements, and then the sizing changes. If you want to put it in the vertical orientation, then you may have to size up. So these are reasons why I would like to do a pre-op UBM, just for those like 2% of cases which you want to be careful about. But I think majority, 98%, if you're a beginner, if you're starting out, then any of these devices, the advantage of the calculator is that you can use any device which is already there in the clinic. You don't have to invest on new diagnostics, and you can kind of start off. And as you do more cases and then you want to refine your technique, then you can invest in better equipment and maybe a UBM. The UBM also is highly operator dependent, so it depends upon the angle of the probe and then how you're measuring. So if you don't measure properly, then again it's not accurate. But if you're good at measuring, then yes, it can be a valuable tool, especially to rule out irises and plan your surgery.
About the UBM, do you think, would you recommend it to use it in extreme cases like high myopias? Or do you think that with this formula and using with all the measures and this equipment is not necessary?
I think it's as far as measurements goes, it would make maybe like about a 5% difference. But if you have most of these equipment, which an advanced OCT like the Cassia 2 or the MS39, which has a higher resolution, measures the angle to angle, then that is good enough because you get the lens rise also, and fairly accurate, fairly predictable outcomes. The UBM, of course, like I said, for irises, there's nothing else to rule out irises. And then you can have this in some patients, and you can get into trouble with these patients. So that's why I like to, because we do fairly good volumes, and we want to be as accurate as possible. Also, we look at the data, we look at the pre and post-op UBM, because I want to see where the lens is sitting. So another very interesting fact is with the Eyecryl Phakic, the haptics are stiffer, so it sits in the sulcus. If you have a very soft foot plate, and then what happens is the foot plate folds, and many a time, almost in I think the studies, other studies also, which show that 50-60% of the time, the lens with the soft foot plate actually is not sitting in the sulcus. It sits on the ciliary body or on the zonules, and that's why the walt prediction also becomes so much more difficult, because you are assuming that the lens will sit in the sulcus, and you're doing all the calculations for that. But if the lens itself is not sitting in the sulcus, then it throws off everything.
Another question, Dr. Ganesh. It seems that you, in a toric ICL with a rotation, it seems that you choose a larger size in order to improve stability. But in spherical IOLs, if you have a doubt between two sizes, do you feel more comfortable with a larger or a smaller bolt after the surgery?
See, with a non-toric lens, when you're putting it in the vertical direction, you can actually err on the side of a higher walt, because if you have an intraop OCT, we have an intraop OCT, we have an IOCT. So what I do is, if I see that the walt is higher, say it's like 900 microns, and then I kind of rotate it into the vertical axis, you reduce the walt by almost about 300, 400 microns. So it comes within that sweet spot of about 500 plus or minus 100 microns. So if you go very low, suppose you select a lower walt and put it in the horizontal, then there's nothing much you can do. You have to exchange it. So that's the logic, because the vertical sulcus to sulcus is larger, and you can use this if you have a large vault. Instead of exchanging the lens, if it's non-toric, you just rotate it in the vertical direction and the vault actually reduces.
Thank you very much. Any other questions? Okay, so, okay.
Shri, related to the vault only, you said that most often we place it horizontally with a slight change, vertically only spherical lenses, occasionally it can be changed. Your concept of 0.5 millimeters will definitely take care of stability of the lens, but doesn't it lead to higher vault in many cases?
No, if there is a higher vault, then you can always rotate it vertically. If it is a non-toric.
Yeah.
If it's a non-toric. If it's a toric, you can't rotate it. But toric lenses also, I like to kind of be within 15 degrees. With Biotech, it's usually within 15-degree rotation. With a star, it goes up to 22. So if you have to rotate it quite a bit, then the lens becomes unstable. And yeah, I think we should close the session because they are signal. Thank you very much. Thank you.
Just last question, just 1 minute. Yeah.
Thank you very much
First
for
question,
beautiful presentations. I would like to ask you about your surgical pearls when we are explanting these lenses, just because we know that they are a little bit more thicker than the competitive ones. So would you give us some recommendations when we remove them?
Yeah,
Thank you.
actually I have some videos. Actually, it's not very difficult. The lens is a little stiffer, but what I do is I actually enlarge the internal lip of the wound. The internal margin, I enlarge it to about 3.2. So the external wound is 2.8, the internal is 3.2. So I have a trapezoid incision. Then I go in and hold the optic haptic junction, and with a twisting motion, I can very easily remove it. So that's a very easy way of explanting this lens, and rather than the hand over hand technique. So it is not difficult to explant the lens for exchange or if you have a cataract.
Okay, we have to finish. Thank you, Biotech, for bringing us together in this exciting symposium, and thank you all the speakers and the panelists for their insights, and well, thank you all of you for your participation.